So coming to hepatitis D virus implications for India. So actually, the bulk of the attention is on the hepatitis B, C when it comes to chronic hepatitis B, and A and E when it comes to acute viral hepatitis. So hepatitis D virus is the neglected one. The reason being that most of initial studies had shown that hepatitis D virus is quite prevalent in our country. But then as the subsequent studies were done, its prevalence was found out to be very low and it was not clinically significant. So that's why the researchers also and the policymakers also lost interest in hepatitis D virus. And the screening for this test is not routinely done. But since we are doing a master class on hepatitis, so that's why we should not be leaving any virus behind. That's why this topic has been included. So it has more of academic interest and theoretical interest rather than practical interest in your day-to-day practice. So with this disclaimer, let's start with hepatitis D virus. So hepatitis D virus, it doesn't occur in isolation. It can infect only those individuals who are already infected with hepatitis B virus. So the reason for this is that the envelope of this hepatitis D virus, which is required for penetration of the host cell, is formed by the HBS surface protein of the hepatitis B virus, which is not manufactured by the hepatitis D virus. So it is dependent on hepatitis B surface antigen for its penetration into the cells. So that's why it cannot infect an individual who is not already infected with a hepatitis B virus, because then it will not be able to penetrate the host cell and it will be eliminated. So that is one of the important point regarding hepatitis D virus. So hepatitis D infection patient who are co-infected with hepatitis B virus result in aggressive form of viral hepatitis, and this combination accelerates the disease progression. And those who progress to chronic hepatitis with this combination, approximately 70 to 80% develop cirrhosis within few decades without treatment. And in general, up to 5% of hepatitis B infected individuals are also infected with hepatitis D virus. This is the global data, not specific to India. However, as I told, true prevalence is likely higher due to underutilized screening methods. Because in our country, routinely we do not do hepatitis D virus screening, so we may not be knowing what is the actual prevalence of hepatitis D virus. So hence, it is most likely underreported. So this picture shows the global prevalence of the hepatitis D virus. Here you can see that in the dark brown color shows the countries which are having higher prevalence of the hepatitis D virus, and the Indian subcontinent comes into the intermediate range, whereas the North America and parts of South America also come into low and low intermediate group. So the hepatitis D virus has 8 genotypes, and depending on the geographical location, it is prevalent in different locations. And you can see that predominantly genotype 1 is the one which is dominating in most of the geographical areas, followed by other genotypes. So predominantly genotype 1 is the predominant one which is found throughout the globe. So coming to the Indian data, whatever is available on hepatitis D virus. So the first report was from the state of Kashmir in the year 1998, where Kuro et al. Identified an outbreak of hepatitis in an endemic area of hepatitis B individuals. So the area was already earmarked as endemic for hepatitis B virus, and there was an outbreak of acute hepatitis. So then they investigated for the presence of hepatitis D in this community, and they found out that 35 of the 51 patients with jaundice were hepatitis B virus carriers, and out of those, 22 patients had hepatitis D virus superinfection. And this prevalence was quite high because this was the first study, and never before we had done study in our country on hepatitis D virus, and the high prevalence was found in this group which was suffering from hepatitis D virus. And the disease occurred in the age group of 28 to 38 years of age, and with no gender predilection, male and female were equally affected. 3 patients with hepatitis D super infection presented with fulminant hepatic failure with a fatal outcome. And all the patients who had non-fulminant hepatitis D virus showed apparent recovery. So those who had acute viral hepatitis, 3 patients had fatal outcome, and rest of the patients had an good clinical course and they recovered in due course of time, as is seen with other viral hepatitis. However, at 4 years, 7 patients with HDV superinfection had evidence of chronic hepatitis. So 7 patients progressed to chronic hepatitis, and one of these 7 patients died due to progressive chronic liver disease. This was the first study which gave an account of hepatitis D virus in the country in the year 1998. So after 1998, there was a gap and no significant study was reported from India. And then there was an attempt to once again see the prevalence of hepatitis D virus in India. Then in 2015, from our institute only, Amit Goel sir and the team studied 318 patients with chronic hepatitis B for the presence of hepatitis D virus. And to the surprise, none of these patients had any evidence of anti-HDV antibody, meaning that they were not infected with hepatitis D virus. Similarly, another study was done from ILBS New Delhi, and they also found out that they could only find 2 patients out of 200 patients who had anti-HDV antibody positivity. So they also showed that the prevalence of hepatitis D virus is very low in our country, and it does not mandate a screening program so that we start doing hepatitis D virus screening for all those people. It is not cost effective. And another study, latest study in 2022, was done from the state of Tripura, where they study 119 patients of chronic hepatitis B, and they found out a prevalence of 4.2%. So although some positivity has been reported in various studies across the country, but the prevalence is so low that we cannot recommend routine screening of all patients with hepatitis B for hepatitis D antibodies, because it is not cost effective. And still further we need to do more epidemiological studies to see what is the true prevalence and whether this presence of hepatitis D is actually having an impact on the clinical course of chronic hepatitis B patients. So after studying a few, discussing a few studies from India, so let us go into the structure and the unique things about hepatitis D virus. So hepatitis D virus, as previously told, is a satellite virus which is reliant on hepatitis B for its life cycle and is categorized as defective or incomplete virus. So its structure has a particle of 35 to 37 nanometer size, harboring a delta antigen and circular single-stranding RNA genome, which is covered by HBsAg from hepatitis B virus. So this enables the hepatitis D virus to exploit the same entry receptor, that is NTCP. So what is the full form of NTCP? Anyone? You are studying hepatitis B virus from the morning and everybody is teaching you the life cycle of hepatitis D virus entry. So if anyone can tell what does NTCP stands for? This is the entry receptor of hepatitis D virus, B as well as D. So anyone? N stands for sodium. So if anybody can take on from this, sodium taurocholate co-transporting peptide. Okay, so NTCP receptor is the same for hepatitis B as well as hepatitis D, because the envelope of hepatitis D is as HBsAg antigen. So that's why they utilize the same entry point. This thing is to be kept in mind. So inside hepatocytes, the uncoated hepatitis D genome moves to the nucleus, and from there on, they utilize the proliferating machinery of the host, and then they proliferate. And when the proliferation is complete, then once again, for the release of the hepatitis D virus from the hepatocytes, once again, the requirement of hepatitis B surface antigen is required. So this is the structure of the hepatitis B virus. So the envelope part is of the hepatitis B virus, that is HBsAg, and the genome inside it contains the RNA genome of the virus. So it utilizes the NTCP receptor, which is also the entry receptor of the hepatitis B virus. So once inside the cells, it loses its envelope and it utilizes the proliferatory mechanism of the host cell, like polymerases, RNA polymerases. It proliferates, it develops its RNA, and once RNA have developed, it once again is coated by the HBsAg of the hepatitis B virus, and then it is finally released into the cell. So almost all the significant entry, exit, as well as cycling of the hepatitis B virus is dependent on the hepatitis B virus surface antigen. And why this life cycle is important? Because the treatment that is given also targets some of the steps of the proliferation, like this entry inhibitor. One of the drug you must have heard, bulevirtide. It inhibits the entry of the virus into the cell, so bulevirtide acts at this point. Similarly, there are prenylation inhibitors, which is lonafarnib. So it inhibits the prenylation of the hepatitis B RNA, and hence it inhibits the release of this hepatitis B virus. And then there are interferons. Interferons, you know that they increase the immunity and suppress the virus. These are the three main mechanisms by which we can control the hepatitis B virus. So hence it is important to know about the life cycle and all of the hepatitis B virus. So now coming to the natural history. So as I already told, there are two forms of hepatitis D virus. One is simultaneous co-infection of hepatitis B and hepatitis B. Whereas another one is that for patient has already hepatitis B virus. On top of that, patient is getting hepatitis D virus. That is called a super infection. So one is the co-infection in which both of the viruses are getting introduced into the body at the same time. And the another one is the super infection in which on top of hepatitis B virus, the patient is getting hepatitis D virus. So the important thing to remember is that in co-infection, usually the presentation is like that of acute viral hepatitis. So patient will be having prodrome, jaundice, icterus, and then subsequently recovery occurs in almost all the individuals. So in patient, those who have co-infection, usually recovery is the rule, and progression to chronicity is very rare. Whereas those who have super infection, already a patient has hepatitis B virus infection with profound amount of HBsAg in the body, and on top of that HDV infection occur, there the prognosis is poor and the chances of rapid progression to cirrhosis and HCC are higher in such patients. So if at all one has to have hepatitis B, D co-infection, it is better to have co-infection rather than super infection. I hope this point is clear. So another point to remember is that during 1 to 15 years of follow-up, it has been shown that histological deterioration is to the tune of 77% of the patients, meaning that those who have super infection, almost 2/3 of such patients will develop cirrhosis. Hence, it is very important to detect HDV, HBV super infection and treat it. And HDV infection increases the risk of HCC by a factor of 3.42 as compared to those individuals. If a patient has only hepatitis B virus infection, suppose the risk of getting HCC is 1, then in a patient who has both the infection, the risk of getting HCC increases by 3.42 times. So it is quite a substantial number. So hence, this HDV, HBV co-infection is very bad for a patient. So this is the pictorial representation of the natural history of hepatitis D virus, which is the steps will remain the same, like that is from normal liver to chronic hepatitis, cirrhosis, and carcinoma. The rapidity with which it occurs and the frequency with which it occurs, it increase. Cirrhosis will develop in 75% of the patients of hepatitis D virus within 15 years. Whereas this rate is quite low, 20% in 20 years for hepatitis B and C. I hope you remember this one. So here, if the patient remains untreated, so in 15 years, 75% of hepatitis B, D patients will progress to cirrhosis, which is quite high. So you can see the difference it makes when we get an additional virus along with hepatitis B virus. So then comes the factors. What are the factors associated with fibrosis progression? So the genotype plays a role, genetic characteristics, ethnic group, male gender, advanced age infection, along with alcohol consumption and risk factors like diabetes, obesity, and immunodeficiency. If all of these factors or one of these factors is present, then the patient has higher chances of progressing to cirrhosis at a rapid rate. And once cirrhosis develop, then we know that decompensation and HCC will occur. So then how to go about it? So ideally, what is recommended by American and European societies is that we should always screen for anti-HDV antibodies in a patient with HBsAg positive. This is not recommended for India at present, but this is the global guidelines which are followed all over the globe. So if any patient is diagnosed with HBsAg positive, anti-HDV antibodies should also be tested in him or her. If they come out to be negative, then no need to go further. That is the end of the story. You treat the patient for, you manage the patient for a chronic hepatitis B, and you need not do anything else. However, if anti-HDV come out to be positive, then you need to measure the HDV RNA levels. If HDV RNA levels are negative, then also like HCV RNA is negative, we need not do anything. Same is the case here. If HDV RNA is negative, that means the HDV infection either resolved or it is controlled. So no need for any treatment. So you can follow up such patient, but no need for treatment. However, if HDV RNA comes out to be positive, then it means the patient has active HDV infection. So if the patient has active HDV infection, so like you evaluate for hepatitis B and C, you have to do non-invasive tests like APRI, FIFO, fibroscan, ultrasound to look whether the patient has high fibrosis or cirrhosis. So if no or minimal fibrosis is present and ALT are normal, there is no need for antiviral therapy. And if the patient has decompensated cirrhosis or acute liver failure, then patient is a candidate for liver transplant. He has to go for liver transplant. However, if the patient has advanced disease and ALT levels are elevated along with compensated cirrhosis, so these group of patient mandate antiviral therapy. So then you discuss with the patient about the treatment options, its side effects, and its duration, cost, and all. And after you have done all those things, then you start treatment depending on the what treatment is available in our country. So as per guideline, we can start with the pegylated interferon alpha. Along with that, bulevirtide, we can also start. So what is bulevirtide? Acts at what point? Yeah, good NTCP. So it prevents the entry of the virus inside the cell. So bulevirtide can also be used. And like I told, lonafarnib, it prevents the prenylation of the RNA of the HDV while it is proliferating. So these drugs are still in trial, but they will be available shortly. And even if you want to ignore these drugs, you have to remember that pegylated interferon alpha and bulevirtide are the treatment options. And some studies have also used combination of pegylated interferon alpha along with bulevirtide. So this is the treatment that is available for hepatitis B virus. So one thing is to be kept in mind that hepatitis B virus you have to treat as you treat for hepatitis B virus in isolation. So treatment of hepatitis B virus will continue. This is in addition to hepatitis B virus, you have to treat for hepatitis D virus because we know that hepatitis D virus will not occur in isolation. So it will occur in combination. So then you will treat the patient with pegylated interferon alpha and bulevirtide, and then you will monitor the patient and assess the treatment response. So ideally, if HBsAg loss occurs, that means the patient has been treated. But in reality, HBsAg loss is very rare. So what you can do is you can see whether HDV RNA becomes undetectable at 24 weeks post therapy or more than 2 log reduction of HDV RNA at the end of treatment. So these are your treatment response assessment parameters. So one thing to remember is in case ALT levels are elevated, patient has compensated cirrhosis along with hepatitis B virus, you need to treat for hepatitis D virus. What are the treatment options available? Pegylated interferon alpha and bulevirtide. Many drugs are in pipeline which are being assessed, so you can omit that part. How do you assess treatment response? HBsAg loss, or after 24 weeks you can assess for the decrease in the HDV RNA level more than 2 logs or disappearance of HDV RNA. So every 3 to 6 months, then you can monitor such patient with HDV, RNA, STLT, HBsAg status. And as you do with hepatitis B, USG abdomen with alpha fetoprotein every 6 months for patient with cirrhosis. So to conclude, patient with hepatitis B positive status should be screened for anti-HDV antibodies. But this is not followed in our country. It is also not in our guidelines. However, ideally, this should be done. Acute hepatitis B co-infection is self-limiting in most of the cases. Whereas chronic hepatitis B, hepatitis D co-infection progresses rapidly to progress. So in 15 years, how many percent of patients will progress to cirrhosis in hepatitis B, hepatitis D co-infection? If you have seen the slide properly, 75%. So it is quite high. So if anti-HDV antibodies are present, then you have to test for HDV RNA. And if HDV RNA is detectable along with deranged LFTs or presence of cirrhosis, you have to treat the patient. And what is the treatment for hepatitis D virus? Pegylated interferon alpha and what is bulevirtide? Entry inhibitor, and it acts on which receptor? Anti-CP. What is the full form of anti-CP? Okay, so my job is done. I think you have learned good things about hepatitis B virus. Thank you.